Oh, well, thank you so much, Dr. Bodeman. That was such a great talk on pH and impedance studies, and I'm sure it's very helpful for our APPs. I'd like to introduce our next speaker, who we actually heard earlier today, Dr. Rosman. Dr. Rosman is a radiologist in the Division of Abdominal and Interventional Radiology at MGH, and he'll be presenting again on barium studies in the eyes of an APP. With that being said, I'll hand it off to Dr. Rosman.
All right, perfect. Thank you so much. Really appreciate being back. And this talk is going to be a little bit different from the last one. And if you weren't able to catch it, then catch it on the recorded session, because that one was a lot more pictures and trying to understand the diagnoses and situation. This is going to be more of the you're on the floor or you're working up an outpatient. You're trying to decide which test to do, what's the right test in the circumstance. There are so many different ones to order. How do we think about it and approach it? So we'll start there. So fun and fluoro, really? Are you kidding? That's at least what my residents think. If it's not CT or MRI, they don't understand why we'd bother. All right, so here are the different studies that you're presented with when you're trying to decide what do we order in these circumstances, right? Do I want a barium swallow? Do I want an upper GI, which includes the stomach and the duodenum, a small bowel follow-through, a single contrast upper GI versus when we talk about a barium swallow or upper GI, really what we're talking about is a double contrast examination, and a modified barium swallow. All right, so when for each exam? So the modified barium swallow isn't me. Depending on your institution, it might be radiology will help with it. Occasionally, it's almost always the case that speech pathology will use our equipment, and oftentimes they'll ask us for some advice along the way. But for the most part, this is a different exam. It's not a radiology ordered exam. And it's for those patients who have difficulty swallowing and you're trying to figure out about aspiration and what foods they can have and techniques they can use for all of those, et cetera. Clearance for food if they need it, or the other way, which is clearance that they can't have food and need the PEG, et cetera. So modified barium swallow, not radiology, but it's a management of aspiration and swallowing sort of exam. All right, so single contrast esophagram. So why, oh why would you do this when the double contrast ones are so pretty, right? I love those pictures. Why would you ever want a single contrast? Well, they're really about perforation studies. These are questions usually post-op. They might be after the big Thanksgiving dinner and the possible blowout and all of those questions about that you're not asking a mucosa question, you're asking a perforation question. Now, here's the problem, right? You don't want water-soluble or barium. Now, you're usually not going to order this. You're going to order a barium study, but you might end up getting a call from the persnickety resident of mine who says, well, you ordered barium, but we don't really want barium in this circumstance. Is it okay if? And you're just going to say, well, whatever you want, right? Because don't you do the exam radiology? And so, fine. But I at least want you to have a little information here. So you don't want water-soluble in the chest because it can cause a mediastinitis. And so that's bad. And you don't want barium in the chest because it can tattoo and cause a mediastinitis, and so that's bad. And then you have too much water soluble. Not only will it cause a mediastinitis, but its osmolarity will pull in fluid into the chest, and so then you make somebody drown. So that's not good either, right? We really, really don't want to make our patients drown from inside. Terrible, right? So you don't want to do either, but we've got to. So what do we do? Well, I use water soluble, but as little as possible, right? So small sips. Now, why am I going to use both when I don't want to use either? Good question, Dave. Thanks. So the reason why is because water-soluble is less damaging than barium, but it is less sensitive. Barium is denser. We see it better, and we're more likely to see the leak. And so if you have a big, huge leak, you'd rather have used the water-soluble, just a small sip, and you stop. Right? And you might say, characterize a leak, et cetera. And we say, no, right? We don't want to cause all the damage. There's a leak, right? It's massive, call surgery, right? It's small, question mark, right? Or it's medium, question mark. It's small, watchful waiting, right? And so, so we can at least do that, right? Small, medium, large with the water soluble. But we might miss some of the small ones, so then we add barium, right? And so we'll do it a few sips with barium. If we're not seeing it, then we don't have to worry about doing more in order to try and look because it's not leaking. All right, so that's what we do. Double contrast esophagram, sorry, so a barium swallow as we know it. So these are for all of the different swallow problems that you're not thinking about a modified barium swallow for, right? Dysphagia, odynophagia, maybe it's a hernia characterization. So you're not going to end up performing most of these, but things that I tend to think about and tell my trainees, if it's a high dysphagia, and that's basically above the thoracic inlet, we get cine images of them swallowing, so it looks a little bit more like a modified barium swallow, just to see what the swallow mechanism looks like. lower dysphagia, we end up not tending to do that because it doesn't have the same need, and you'll catch the images down lower. And then I'll always do two different views. As one of my attendings told me a long time ago, is actually a neuroattending. One image is no image. And so you need a couple different views to truly understand what something is. And so I'll do them in RAO and AP. Almost everybody else does left anterior oblique instead of right. They're wrong. And the reason why you shouldn't do that is when you have them do the drinking images later, then it turns out to be really, you get already a LAO equivalent drink. So that's that. And then they get the GE junction. That's where the action is. When we're imaging, we want to make sure that we're going to get the GE junction because most pathology happens there. Is the other stuff? Sure, I showed you other stuff, highest strictures, mid strictures, mediastinal things. There are a lot of disease that happens in other places. But those are the case collection things that you put in and you see very infrequently. What do you see every day? We see GE junction abnormalities, and so that's where we spend most of our time. Okay, so in upper GI, I bring this part up because a lot of time people want a barium swallow and they order an upper GI. And the question is, it's more work for the patient. It's more radiation for the patient. It is more work for us. But the question is, do you need it, right? Are you trying to evaluate the stomach and do duodenum? Or are you really just looking at the esophagus and the gastric cardia? Because we'll get the gastric cardia in a barium swallow. It's about the rest of the stomach, the body and the antrum and the duodenum, that you need the upper GI. So there's a whole lecture to be given about doing an upper GI, but this is for anything where more than just the esophagus is involved, right? Epigastric pain, nausea, vomiting, ulcers, benign versus malignant. Most of this stuff you're doing in endoscopy. We don't need to, but I still like to. They're fun. And then cancer. So what we try and do from a imaging perspective is we want every surface in single and double contrast. And the bulb takes art and its work. And by the way, what I used to do in my old institution is I would give all of our patients gastrographin, just a very small amount, right, 0.1 milligrams IV, unless my resident was doing, in which case it was very often IM accidentally. And so, the advantage to that is it slows things down and helps us see the bulb so much better. It frankly helps us see the esophagus. We get better double contrast images. The problem is you can't do that anymore. God bless you, Jaco. You have to use an entire vial for one person. And when you do that, the vial of gastrographin costs more than the entire reimbursement for the entire examination, and therefore we can't do it anymore. Hooray, patient safety. All right, so small bowel follow-through. A lot of people order upper GI and small bowel follow-through when all they want is a small bowel follow-through. All right, attention to everybody. You may get a small bowel follow-through without getting an upper GI. I mean, don't get me wrong, they got to get the contrast to them somehow, but we don't have to take all of the images of the upper GI, of which there are, about 30 images to get it done properly. And if all you're really looking for is, I want to know about transit time, or I want to know if the obstruction is clearing, or we're trying to look for diffuse small bowel disease, or celiac disease, etc., that you can get a small bowel follow-through alone without having to get all the upper GI. If you want the upper GI small bowel follow-through, great, we are happy to do it for you. But remember, you are allowed to get, it's okay to get a small bowel follow-through without also getting the upper GI. And I spot with an F-spoon because I always want to see all four quadrants and the TI. The F-spoon is this gray one here that looks like an F. It was made by a guy named Frank. That is true. I don't know whether that's why he called it an F-spoon, but it really just gives us good leverage without getting our hand in the field. In the olden days, you'd see people put on one of these radiation gloves and put their hand in the middle of the field. The radiation glove is to protect my hand when I wear the F-spoon. It is not meant to go on the patient. The reason why I don't want it on the patient is anything super dense means that the detector has to use more radiation, and that's a terrible idea. You don't want to do that. So we don't. All right. So positions, those are defined by the part of the body closest to the image receptor, right? So right anterior oblique means the right and anterior surfaces are closest to the image receptor. The LAO left and an anterior are PO, LPO, etc. So they're defined that way. So here's a person in LPO. Why? Their left side is closer to the detector than the right side, so that's L, and their posterior is closer to the detector than their anterior. So it's left posterior oblique, and I won't do all the rest, but that's how we name all of our positions. Oh, I did this one. Right anterior oblique. See, I will do all of them. Are you ready? Here are 10 more. No, I'm kidding. Tools of the trade. Here's the reality is this is a live exam, and that's great, right? CT, you push a button and it happens. In MR, you push many buttons and it happens. And that's great, and they are important, and I love those, and I read a lot of CT and MR as well. But what's great about this one, from a radiology perspective, is we've got the patient there. And if we're seeing something we want to see better, we can just say, I want to see it better, and turn the patient a certain way, move the camera a certain way, magnify, cone, etc. You do all these things, and it helps an awful lot. Compression is another thing that we use that helps an awful lot. It thins a thick patient or thins a thick thing. We see a lot more by using that sort of compression. And you can actually put quite a lot of compression without hurting people. I have broken F spoons on patients. Colleagues have broken F spoons on me by pushing really hard. It turns out if you push really gradually, it doesn't really hurt unless the person is post-op. This is Rwanda. That is all T. That's cool. And then just a reminder, right? The A ring, B ring, C ring. B is what you are really looking for abnormalities, even though A looks really impressive here. A is just a junction of the tubular and esophagus and the phrenic ampulla. And B is where the squamocolumnar junction is. That's where the disease really ends up happening. C is the diaphragm. That's where we look for hernias. The question about should you use a tablet or no, I have some colleagues who say use a tablet every single time. If you want a tablet used because that's your preference or the attending that you're working with, their preference, then just make sure you request a tablet because not all of us will use all of the time. It does increase sensitivity for certain things. I showed that case earlier today of eosinophilic esophagitis where the tablet gets stuck mid-esophagus and the whole esophagus was a little strictured. And sometimes when an entire organ is abnormal, you don't notice because the whole thing looks right. There's no transition. So the tablets can help. And there have been good examples of cases where it looks normal, you give a tablet, it gets stuck somewhere, and there was disease. So in general, it really does add additional sensitivity. It's not uber critical, but it is a nice thing to do. Hernias, this is an axial sliding through a normal hole, right? So, and sometimes through an abnormal hole. So the hiatal hernia is sliding. It's a fixed or a short, sometimes from a fixed short esophagus, but we'll see paraesophageal hiatal hernias. This is, again, a really nice way for us to be able to see and characterize these, to understand surgical approach that needs to be taken, whether or not they need to be repaired. That's often a reflux question rather than is there a hernia question. The goal for us is identify the EG junction, which sounds like it's a really easy task, but sometimes with really complex hernias can be difficult. But when you find the EG junction, then you know what hernia you're dealing with. So a couple examples of a paraesophageal hernia. The first image and the second, this is the same patient, and you can see how in the AP image, it's really hard to see what's going on and what goes where and what's going through what space. But you can see clearly in the second image that there are two holes, right? The esophagus, the GE junction is down here, right? And then separately, we've got a portion of stomach herniating through a separate hiatus. So reflux, we look for reflux. You just got a great lecture on reflux. This is not the primary thing for reflux, although sometimes it seems as though it is used as the primary thing for reflux. And we look, there are a lot of people who will do the water siphon test. I happen to believe that the water siphon test is a good indication of whether or not you did a water siphon test. If you have somebody to stand on their head, drink while standing on their head, and then intentionally open their GE junction and stuff doesn't come through, then we are defying the law of gravity. And so I just think that it's silly. On the other hand, putting the person in sort of a bad position, which is a little bit of head down, and then in a RPO position, that puts all of the contrast after prone drinking right against the GE junction. And then we have them do Valsalvas and cough and inducing maneuvers, and that's when they reflux. It is a reminder to everybody, do not sleep in an RAO position, particularly if you have a lousy mattress in which your head is down. That is a really good way to reflux yourself. ESD, we look at all of these different components, so it's actually a pretty significant, this is the upper GI. This is where we're looking for every part of the stomach. Small bowel exams, small bowel follow-through, we'll do every 30 minutes usually for imaging, unless it's just a delayed transit examination in which we want to image them less often. Because 30 minutes for high-risk small bowel, 45 minutes for low risk. The thing is if you're ordering it, it's high-risk bowel. Pain and bleeding, et cetera, are all on there, right? And then we'll do a lot for post-esophageal gastrectomy and post-ops. These are all single contrast examinations because we're looking for leaks and we're trying to see the anastomosis. Same thing for perforation. We're trying to see leaks, and so we're using gastrographin followed by barium. And then same thing, right? Big leak surgery, small, take a look and observe, we'll see. And then intramural, and it's just inside and it's not leaking out to the chest. Those are usually going to be observation cases. So we do the post-op and morbid obesity, again, gastrographin, then barium, just looking for leaks and looking to see whether or not it's strictured. Again, the sensitivity is reduced there because there's post-op edema, so it'll always look a little bit strictured. And so parting thoughts, right? Fluoro is live. That makes it fun. The things that I always tell my trainees is think and then fluoro. If you are thinking when your foot is on the pedal, that's not good. If you're not thinking at all, that's not good either. But you don't want to think when you're doing that cardiology, then you want to sometimes be careful. And then we, I think, don't have time for questions, but there'll be a question and answer session later. So thank you all very much.